And by March 11th, 2020, the Secretary General of World Health Organization has officially declared COVID-19 a global pandemic, coming in with its many devastating effects on virtually all areas of life, name it, education, finance, international relations, and all that, including bringing in very costly effects on some of the most developed health systems of the world, which is why nations of the world started to put up measures on how to combat the spread of the virus. Part of the measures was to introduce a lockdown. And of course, with the lockdown came simply intensified the vulnerability of women and girls. And that found expression in issues like teenage pregnancy, like gender-based violence, and like a surge in the practice of female genital mutilation or cutting. So this is why today we want to look at this very important issue, the impact of COVID-19 on sexual reproductive health and rights of the women and girls. Part of the things we'll be looking at very quickly before we bring in our panelists, we'll be looking at the overall impact on the sexual reproductive health and rights of the women. We'll also be looking at the roles of men and boys when it comes to ending FGM. We'll also be looking at the roles of religious leaders and perhaps take some time to appraise the commitments from ICPD on social reproductive health and rights of women and girls. As interesting as the topic, so are our panelists today. Yes, we have very great sets of wonderful, wonderful people, our champions indeed. And I'm just going to bring in Joyce, Dr. Joyce, to introduce them in no particular order. So, Joyce, you have the floor.
Thank you so much, Paul. Welcome to the panel. So I'm going to introduce the speakers. As you heard, my name is Dr. Joyce Omwoha. I'm from Media Studies at the Technical University of Kenya. So I'll start in no particular order to introduce our speakers this evening. Robert Kasenene works with the African Union Commission Development of Social Affairs as Coordination and Advocacy Specialist, coordinating the AU's Saleema Institute. A champion of women's empowerment, he is dedicated to advancing action to address particularly gender-based violence in all its forms as a key impediment in Africa, realizing its full potential. Robert has over 15 years experience working on youth development, leading efforts in Tanzania to deliver youth-friendly health services, and later working with AU Youth Division to develop and launch the Youth Volunteer Program of the AU Commission. He spent a number of years promoting youth leadership in the sexual and reproductive health rights space, actively creating spaces in regional HIV/AIDS policy spaces. He participated in the ICPD review in 2014 and 2019, and in multilateral negotiations, including the Commission on Population and Development and the UN General Assembly. Robert is a strong supporter of MenEngage Africa's work, specifically in driving the agenda for engaging men and boys in ending all forms of gender-based violence, including harmful practices such as FGM and child marriage. Welcome so much, Robert. We are looking forward to your expertise on this. Next, I will introduce Dr. Muna Abdallah. I'd like to note that our speakers' faces are there. Muna is waving, so you can see whom exactly I'm introducing. Dr. Muna Abdallah is a health system specialist working at UNFPA, Eastern and Southern Africa Regional Office. Dr. Muna is a medical doctorate degree from Ethiopia, and Masters of Arts in Population and Development from the Netherlands. She provided technical support to countries in East Africa and South Africa in health system strengthening, for sexual reproductive health, focusing on maternal health. Her area of interest include maternal and newborn health, women's empowerment, data, and evidence around RMNCAH, universal health coverage for reproductive health, information, and services. Welcome, Dr. Muna, to this panel. The next I'm going to introduce is Dr. Tamari Esho. Dr. Esho has a PhD in biomedical sciences, sorry about that, and an MSc in human sexuality studies from the University of Leuven in Belgium. She's a public health scientist and sexual medicine consultant with specific expertise in generating evidence through research, capacity building, planning, and implementing interventions in both family, community, and health systems levels against FGM, sexual and gender-based violence, child marriage, among others, in a bid to promote public health. She is currently serving as a director of the Center of Excellence for FGM, and here she speaks about female genital mutilation and cutting, AMREF Health Africa. Additionally, she is the current Secretary General of the Africa Society of Sexual Medicine, as well as an associate member of the Africa Coordinating Center for the Abandonment of Female Genital Mutilation, cutting. She has, over the last years, been the principal investigator for several studies commissioned by DFID, USAID, UNJP, WHO in collaboration with Population Council and Africa Coordinating Center for the Abandonment of FGM. Furthermore, she works in collaboration with a number of NGO, civil society, community-based and grassroots organizations, Samburu Girls Foundation, among others. So welcome so much, Dr. Tamari Esho. That's an impressive CV. We hope to hear more from you in this session. The next person I will introduce is smiling so broadly as if she knows she's the next one, is Fatima Awil. Fatima is the Policy and Advocacy Officer of the End FGM European Network based in Brussels and was previously an ambassador for the network. She works on implementation of the network's European and international level advocacy activities. Fatima is an experienced advocate with a focus on gender-based violence, FGM, domestic violence, and child, early, and forced marriage. She first started the fight against FGM as a youth advocate with the African Diaspora Organization based in the UK called Forward. Later, Fatima co-founded the Youth Project for Change, a global youth-led network based in Bangladesh, the UK, and Tanzania, which works in partnership with organizations and governments to tackle gender-based violence and create positive change for young people. Thank you, Fatima. Welcome. You're bringing in the touch from the legal side. We are waiting to hear what that is about. Next, I will introduce Mr. Nicholas K. Songok. Mr. Songok has vast experience in public service with organizational development, planning, monitoring, and evaluation. He's currently the Manager Planning Policy and Strategy at Anti-FGM Board and has served as a senior officer in managing cooperative institutions, youth, and women organizations. He holds a Master of Arts in Monitoring and Evaluation from Maseno University and a Bachelor of Arts from Kenyatta University, a Certified Associate in Program Management, and a Certified Specialist in Monitoring and Evaluation. He is a member of the Evaluation Society of Kenya. Mr. Songok is a dynamic and results-oriented professional with over 10 years experience in planning, monitoring, and evaluation. He has a track record of ensuring that his assignments are run smoothly and are completed within time, while putting emphasis on quality output coupled by his abilities to coordinate, make timely decisions, and ensure that activities run at maximum efficiency. Thank you so much, Mr. Songok, for being here.
Yeah, thank you, Joyce. I'm happy to be here.
Thank you. You're welcome. All right, and last but not least, I'm going to introduce Sheikh Tawfiq. Sheikh Tawfiq is a Muslim scholar who has worked and preached over the years towards ending harmful practices in Tarim, Tanzania. He has become an ambassador advocating for ending FGM using mosque sessions and madrasa. He has worked with Children's Dignity Forum and MenEngage Tanzania to contribute to advocacy around increasing the age of marriage to 18 in the marriage law. You're welcome so much, Sheikh Tawfiq. It's good to bring in the religious aspect, and this is amazing work you're doing out there in the mosque. Thank you, panelists, for being here. And we are hoping to engage coming from different areas. We would like to hear the expertise. The CVs are very impressive, and we are hoping to hear more. I will hand over back to Paul, who will take the first session of this symposium. Thank you. Paul?
Yeah, thank you, Joyce, for that great work. Yes, we have a very interesting set of very wonderful people on our panel today. But I'm going to just say this. We have, I think, Sheikh presenting in Swahili, and you have access to a translation in English and in French. I suppose that as well. And participants, please feel free to just drop your questions or comments in the chat box. And then our panelists as well can respond to questions and comments also. So we have information going on there as well. So I'm going to start with Fatima. Fatima, how are you?
I'm well, thank you. How are you?
Oh, great to have you.
Happy to be here.
All right. Let's look at the practical effect from your experience in your organization, your community, or your country, the practical impact of COVID-19 on SRHR.
Perfect. Yes, absolutely. I'm happy to talk about this, and I'm happy to be at this event. It's an honor to be speaking amongst such great panelists. Before I talk about this, because I think it's quite important, I think it would be necessary for me to maybe explain a bit about the network and how we work at a practical level to kind of explain how we gather information. So I work as a policy and advocacy officer for the End FGM European Network, and we're an umbrella network based in Brussels with 30 organizations based in 14 European countries. And as a network, we're really quite unique as we're the only European-wide network which specifically works on FGM. So with our members, they're very committed to eliminating FGM and they have a wealth of experience from providing support services and care services to FGM-affected communities, to providing research, to providing on-the-ground support, and many of them are actually community-based organizations. So in order to kind of set the context and understand more about how this pandemic was affecting Europe, alongside, affecting the world, it has had a huge effect on the sexual and reproductive health rights of women. So what we did in relation to this is we carried out an internal survey among our members to really find out what was happening on the ground. And in light of this, we really found out that the impact was dire in terms of these services and the supports for FGM-affected communities, but more broadly, GBV, tackling GBV and SRH services. And in Europe, we saw two sides. So on one hand, whilst travel restrictions, for example, may have lowered the rates of FGM continuing because, for example, families weren't able to go back home to cut their daughters, we found out that actually this doesn't necessarily mean that there is an absolute reduction, because children were staying at home due to the lockdown for a prolonged period of time, which means that there's a lack of connection and communication with them, and there's more opportunities, for example, for cutters to carry out the practice. We also have heard about the increase, of course, of domestic violence and increased abuse. And we also know that in some cases, for example, Spain, the cases of confinement at home and disruption of protection measures for girls may have put them in jeopardy, especially in places where communities live in shared homes, or they might be easily able to get cutters in. And more broadly, it's really difficult to keep track of what's happening within at-risk communities. For example, in the Netherlands, there have been a number of cases of missing children who were no longer responding to messages from their schools since the lockdown, and these are especially kids from at high risk. And this is particularly concerning because in Europe, it's estimated that at least 600,000 women and girls are living with FGM in Europe alone, and a further 180,000 women and girls are at risk. And this is just based in 13 countries. So we know that the numbers are a lot higher than what it's perceived to be. And when we look at the statistics, there's around 20,000 women and girls seeking asylum on an annual basis from at-risk countries. So we know that the numbers are extremely high. So there's a lot concerning this, but this is just to paint the picture.
Okay, thank you very much. We'll come back to you to make your presentation in about 4 or 5 minutes. But let me move on to Robert now. The same question, just in 2 minutes. From your experience, how has COVID-19 impacted SRHR in your community or country or organization? While we wait for Robert, let's move on to Dr. Muna. Hello, Dr. Muna.
My apologies, yes. I am here, but please go ahead.
Oh, okay, you're welcome. All right, sorry, Dr. Muna, we'll just take Robert in 2 minutes. Just share with us your experience of the impact of COVID-19 on SRHR.
Is that myself or Mona?
Just you now that you're in, so we can as well have you in 1-2 minutes, just to by way of introduction.
Thank you. Yes, my name is Robert Kasenene. I'm seconded to the African Union Commission by the United Nations Population Fund to support the implementation of the AU Saleema initiative on eliminating female genital mutilation. And yes, the impact of COVID-19 on SRHR, particularly on our work, is largely to do with the increasing cases of GBV, including harmful practices such as FGM in our work at the ground level with the countries. What we work towards is zero female genital mutilation, zero harmful practices throughout the continent. We have limited resources to be able to get to this result. But unfortunately, with the advent of COVID-19, there is clear rise in cases of GBV, clear rise in cases of female genital mutilation. And this creates a very added pressure on resources, very finite resources that member states have. And without getting to a level where we're able to integrate the elimination of these harmful practices in national responses, it creates a huge risk in this group that is at risk of undergoing this practice. By 2030, we have currently an estimate of over 50 million girls under the age of 15 in Africa who will be subjected to this practice if we do not take action today to change the trends that drive this practice. And so with COVID-19 and with the added millions who are being added to this risk group as a result of the lockdowns, of the lack of safety in the home, the inability of girls to go back to school, the inability of communities to really advance the changes that we had begun to see in getting away from the social norms that drive this practice, sort of drives back the practice and the great efforts that we were already making on the ground. So in a broad sense, and from the perspective of the Commission and its work with member states to support their work, to support the drive to end these practices, COVID-19 creates a huge gap and pressure to that also creates a reverse in some of the gains that we have seen on the ground. Over and back to you.
Well, thanks so much, Robert. Same experience so far. Now we're going to come to you, Dr. Mona. If you just share your experience in 2 minutes.
Yes, thank you very much. Good afternoon. So in East and Southern Africa region, we have also noticed discontinuity of sexual reproductive health services, especially in the initial period of the lockdown in a number of countries. Initially, these facts were coming out through media. And later on, when I say we, the UNFPA, WHO, and UNICEF Regional Office for East and Southern Africa, we came together and we wanted to look at the service statistics, whether actually these things are disrupting the sexual reproductive health services. So I have a presentation on that, which I'm going to share with you on each areas on maternal health and GBV also. Data is a problem in many countries to have, especially in GBV. We have 23 countries in East and Southern Africa region, but we managed to get only from 4 countries data related with GBV. But the other statistics around skilled birth attendance, maternal days, neonatal days, stillbirths, and so on, I will share my presentation. Thank you.
Dr. Mona, for sharing with us. I understand the Sheikh is unable to log in presently. We hope you'll be able to join in. But while we're waiting for him, I'll just ask Nicholas to please share with us his experience as well.
Yeah, thank you very much, Paul, for leading this conversation. I am Nicholas Songok from Anti-FGM Board, Kenya. We are based in Nairobi. And our work is basically to carry out a campaign against FGM. And just to talk about the statistics is that as at 2007, the prevalence rate of FGM in Kenya for girls between 15 to 49 years was standing at 27. As at 2014, it was standing at 21%. So in one way or another, we were making progress. And at the beginning of this year, we had prepared an acceleration plan, which will assist us in eliminating FGM. But of course, as you realize that from February to March, we had the issue of COVID coming in. And it has really impacted on our campaign against FGM because one is that the issue of resources, the funds that we were using to carry out campaign against FGM, of course, they were used in the area of addressing the COVID issue. And then the other very important issue was that as a result of COVID, we had the total lockdown in Kenya, which started around March. And it is around September. And during all this period, we have had children staying at home. And when the children are at home, we realize that they are at a risk of undergoing through FGM. They are being forced to undergo through the cuts. And the statistics from the Office of the Prosecutor in Kenya shows that during the COVID season, we have had quite a number of FGM cases. And from the month of January to March, for example, we had like 20 cases. But of course, from March to June, we had like 44 cases. So it clearly shows that during the COVID season, we have had quite a number of FGM cases. Over to you. Thank you very much.
Okay, thanks so very much. I understand the Sheikh won't be able to join in, but of course, MenEngage Tanzania will make will present his what he has prepared for us. So let's just look out for that. I'm going to go to, I'll be asking Tammy Ashore to please share your experience with us as well by way of introduction. I hope I pronounced the name correctly.
You did.
Oh,
thank
great.
you, Paul. And hi, everybody. Yes, so my name is Tamari, like you heard. I'm the director for the End FGM Center of Excellence in AMREF. So the center is modeled to strengthen the integration of FGM and child early and forced marriage abandonment into the wider development agenda. And of course, it responds also to emerging issues using a multidisciplinary and community-centered approach. So the center's mandate is to initiate and catalyze multi-sectoral action and advocacy, collaboration, and also building partnerships around strengthening global commitments to accelerate abandonment of FGM. So just to speak about some of the experiences we've had so far in terms of COVID impacts on women and girls, we've definitely seen an increase, just like all the other colleagues of mine have spoken about, an increase in GBV, increase in FGM, and also child early and forced marriage. And this we've attributed to increased vulnerabilities to women and girls that COVID has resulted in dwindling livelihoods of families. And then also due to, and also the other thing that we see is the reduced kind of support and support services and management of SRHR and GBV. The center conducted a study that looked at the effect of COVID-19 on FGM and child early and forced marriages. And some of the preliminary findings that we see is that the perceptions of people who were interviewed in this survey, the ones that spoke about the increasing levels of FGMC within these communities, and the communities were Samburu, community in Kenya, Kajiado, and then also Marsabit. It is a multi-country study, so it involves Kenya, Senegal, Ethiopia, Uganda, yes, so those 4 countries. And we currently have the Kenya preliminary findings ready. The study will be launched before the end of the year. So the people that said that FGMC had increased were 55% of respondents said FGM cases have increased. And this is very different from before COVID, that people said 62% of people said FGM was decreasing before COVID. And now we see a similar kind of level of increase, people saying that it is actually increasing. And then in terms of child early and forced marriage, the data also shows that 64% of people say that child early and forced marriage is increasing. So this is evidence that we are actually finding in the ground. And some of the reasons for this increase, the largest percentage of people, 50%, say that the issue of people staying at home and also the school closure for long durations of time, just really the things that we've been speculating about are actually coming out of our data as evidence that show that actually these are things that have affected our women and girls. The fact that the girls are staying at home, the issue of economic losses within families and of course communities in general, and then also the reduced efforts in programming that support potential victims and also survivors in terms of the closure of rescue centers during this period of COVID have really exacerbated the problem of FGM and child early and forced marriages in the communities that we see. I'll speak about a lot more later. Thank you.
Thanks so much, Ashore. Quite the same experience almost everywhere. We're going to take the presentations now in 5 minutes apiece. We'd like to come back to Fatima if she's ready. We'll be glad to have your presentation. Is Fatima there?
Yes, I'm here. That's
great,
perfect.
Great.
I can
All right.
give my presentation. So I don't have a PowerPoint, so I will just be speaking. But thank you so much. And I've already introduced the network, but just to give some more information, as I mentioned, we have 30 members in 14 European countries, and a lot of them provide different services and support to FGM communities. And close to half of them are community-based organizations that where some work not only in Europe, but beyond. And we also have two fantastic ambassadors program, so for adults and youth, who are the diaspora from FGM affected communities and experts on FGM. And as was mentioned during the introduction, I was previously an ambassador for the network. I'm Somali, so I'm from a community that has a high prevalence of FGM. But during my presentation, I will just like to give some information about some of the feedbacks in terms of the effects on SRHR services, the work that we do and what is happening at a European level in terms of eliminating FGM. So we work to empower community voices and influence the European institutions and policymakers to work towards elimination of FGM. We reinforce our members' capacity, offer spaces for shared expertise, build bridges and develop partnerships. And finally, we campaign and communicate using non-stigmatizing narrative around FGM. And that's really crucial for the work that we do because, as mentioned, even though the prevalence rates are quite high in Europe, there's still a lack of understanding of this issue, which has largely affected even the services that are provided during this pandemic, as it's not considered at all. After some intense years of campaigning by our members, in 2011, the Istanbul Convention was adopted, which some of you may be familiar with, and it's the first legally binding instrument that recognizes FGM as a form of GBV that concerns Europe. So in 2013, our members succeeded to have the European Union actually adopt the first ever EU strategy to eliminate FGM, both internally and externally. So it's really relevant here. And there have been a number of policy successes in the movement, but the one thing that we always push for, and I'm sure colleagues here will talk about, is really the implementation and policymakers really implementing what they've already agreed to. So this is largely what our work is around. And as I mentioned, a great deal of our work has been covering the COVID pandemic, as it's had a huge impact on our members and the movement to end FGM. And yes, it was already discussed, but from the disruptions of services for women and girls, and the challenges around, even if services have kind of reshuffled and refocused, like, for example, being offered online or via telephone, women and girls not having the freedom or the accessibility in terms of having such sensitive conversations on the phone next to their family or children. So it's really not quite the same. And although the strict lockdown is no longer here as it was previously in between March and June, we are really going back to this re-lockdown, which is severely affecting the work to end FGM and SRH services. One of the biggest challenges we've actually been focusing on is the lack of funding, because at European level, as well as globally, we know is there have been reallocations of funds towards more urgent issues regarding COVID-19. And unfortunately, there has been a lack of concern and regard for services on SRHR and tackling GBVs such as FGM and child marriage. So this has been a really, really big issue. A number of organizations have been struggling and actually don't know where their future lies in terms of this pandemic not being something we know is going to end in just a couple of weeks. So this is a huge concern, and it's something that we are incorporating into our advocacy. In some cases, the loss of income and things of this regard have had huge implications for women and girls. And yes, even though support is provided, it's not the same as it was. And even before then, we had huge challenges that we advocated around. One thing I would like to mention is that we talked a bit about ICPD, and in regards to this, one of the things the End FGM European Network has done regarding ICPD, which took place a year prior to the Beijing Declaration and Platform for Action, which very much complemented ICPD. We actually created a toolkit that aims to support national advocacy efforts in light of the 25th anniversary of the Beijing Declaration and Platform for Action this year. And what it does is it looks at the adoption and analyzes the progress that has been made, as well as highlighting the gaps that very much exist. And we know that FGM is very much still a matter of gender equality and was addressed in Beijing Platform for Action, both specifically and within all forms of gender-based violence in severely critical areas of concern, for example, namely women and health, violence against women, human rights of women and the girl child. And the toolkit really pulls out these specific focuses on FGM, SRHR, and GBV, and really highlights things that member states have agreed to 25 years ago and are now more relevant than ever. So we do this in hopes to supporting advocacy efforts so that we use this as an additional tool. And earlier, actually more relevant now, between October and November of this year, there was actually a virtual online stakeholder dialogue that took place where 76 experts from over 40 organizations and 31 countries and 5 world regions gathered online to really participate in a multiple virtual stakeholder dialogue in the run-up to the FGM Donors Working Group meeting that took place a couple of days ago. So on this online discussion, we really focused on preventing and responding to female genital mutilation in emergency and humanitarian contexts. And this, of course, encompasses SRHR and child marriage. And the explicit aim of this was to provide concrete sets of recommendations for donors and key actors in the field. The dialogue was actually organized by a number of organizations such as ADOS in Italy, GAMS Belgium in Belgium, and the End FGM European Network in the framework of the UNFPA and UNICEF Joint Program Supported Project, Building Bridges between Africa and Europe to tackle FGM. And this builds on the work of the COP. I'm not sure whether any of you are subscribed to it, but I can share. But initially, this is a virtual space for dialogue. And this discussion was really fruitful. It took place over a number of weeks. And we have compiled the outcomes of these discussions into a report, which very much relates to this conversation and highlights the work that needs to be done by organizations, donors, and activists. And it highlights the challenges and the solutions, as well as concrete examples of best practices. This will be released later on this month, so I will share with you. But just to provide some information, I will stop here because I know I've been talking for a couple of minutes, but I'll be really happy to expand on this further during Q&A.
Oh, okay, thanks so much, Fatima. Quite an effort your organization has made so far. I like the issue that you raised on implementation and also funding given the pandemic. Thanks for sharing. I also saw your charts and the chart boards. You shared a link for participants to access and benefit. Thanks so much. Yes, in the order in which we started, I'm just going to ask Robert to please, if you can do 3 minutes, that would be fantastic, to give us your presentation.
Certainly, I will give it a very, very strong shot.
Great.
Please indulge me. I have a prepared statement on behalf of the African Union Commission. My head of division for social welfare, vulnerable groups and drug control could not join us and assigned me to be her voice instead. And we have a statement to deliver in that effect. So again, colleagues, friends, ladies and gentlemen, thank you again for the invitation and opportunity to engage with you in this important platform. I bring warm greetings from the Commissioner of Social Affairs at the African Union Commission. And also thank you to, and indeed this is just for myself, thank you to the moderators for the kind introduction and kind words letting us into this discussion. So again, thanks to Sonke Gender Justice for the invitation. I've known and worked closely with Sonke and its wonderful team, as well as the MenEngage network in Africa throughout the years. Your work addressing toxic masculinities, gender-based violence, and gaps in ensuring men and boys engagement in all of these efforts are part of the social change needed to address the gender inequalities existing in our society. have a strong proponent in what we are doing at the Commission on Ending Harmful Practices. The Saleema Initiative on Eliminating Female Genital Mutilation is a program of the African Union, and it was launched by the heads of states in 2019 to galvanize political action and accelerate the elimination of this harmful practice. Working within the mandate of the Commission of convening, providing technical support, and facilitating the implementation of decisions and standards adopted by member states, the initiative looks to advance a coordinated continental agenda, pushing for action on legislation, resource mobilization, evidence and data use, and critically, accountability on commitments to see an end to this gross human rights violation. The impact harmful practices have on the lives of girls and women cannot be overemphasized, and the numbers are very well known and expansive. They deny young girls and women of agency to determine their own health and well-being. And if there was a clear demonstration of how society violates girls and women's bodily autonomy, one of the worst forms of sexual and gender-based violence, female genital mutilation, would be it. So why does this practice happen? What drives such a widely accepted social convention to exist? The answer really, for the most part, goes back to men, myself and everyone else here. It goes back to a social dynamic that is patriarchy. The belief that when an infant, a young girl, or a woman is subjected to the practice makes them pure, acceptable, able to engage in connecting with others in her family and community, that it is a badge for chastity, a measure for marriageability, cleanliness, or the ability to hold social position, among a myriad of beliefs, is largely in fulfillment of the needs of men. And to end and eliminate completely this practice, men and boys must then be a strong part of the process. Men hold prominence in leadership and decision-making. We are community, religious, and opinion leaders. We are fathers, we are brothers, we are husbands, we are uncles. If there is a group to target in changing opinions, perceptions, and to engage in changing the negative social norms that perpetuate these harmful practices, it is men and boys. In communities with preference, studies and programs, and I have followed some of the great work recently around this, they show that when men and boys in those communities are engaged and asked to look closely at what it really means to undergo female genital mutilation, they come out clearly to denounce and abandon the practice. This is where we see men and boys contributing to the African Union Saleema Initiative on Eliminating Female Genital Mutilation. As we work to amplify the work at country level, the work that many of the key stakeholders, such as MenEngage Africa or Sonke Gender Justice, undertake on the ground. And as you know, the Commission does not undertake country-level implementation. We rely very much on encouraging the engagement of key groups and stakeholders, particularly men and boys. And this is also true for the work to address trends like the cross-border practice of female genital mutilation and the medicalisation of female genital mutilation, which other speakers, I think, at some point will speak to, and maybe we may not be able to have enough time to have intervention from myself on these. But in overall, men, for the most part, drive these trends. And the Commission, through the Saleema Initiative, thus regards men and boys as a key interest and engagement group in advancing action to eliminate these harmful practices. And so I look forward to expand a little further on these and exploring further in the discussions going forward. Thank you, and over and back to you.
Okay, thanks, Robert, for that wonderful one. I'm sure in closing, you'll be touching more on how men and boys can contribute to ending FGM. Thanks so much. A question has been left for Fatima. The question is, what non-stigmatizing narrative did you apply? Can you give example? I saw also on the chat board that you dropped a link. Perhaps towards the end of this session, you just touch on that question. But for now, we'd like to have Dr. Muna come in with her presentation in 2-3 minutes, and so we can close in on time that is like running away from us. So let's have Dr. Muna for now, yes.
Okay, thank you so much, Paul, and I'm happy to be in this forum. Representing UNFPA East and Southern Africa Regional Office. My presentation here is the statistics collected from health facilities in 23 countries in the region. But we haven't got all the data, but something like 14 countries has responded. And I will share with you what data we have from the start of COVID. In Africa, it came around March. So the statistics we have collected is February, March, April, 3 months of 2020, compared with similar months in 2019. If there is any increase or decrease, marked increase or decrease between these 3 months, as comparable months between 2019 and 2020. This data was collected with the 3 agencies, WHO, UNICEF, and UNFPA in each country in consultation with the Ministry of Health. The data we have analyzed is only those data verified by the Ministry of Health, which come from the Health Management Information System, or in some countries, some other systems like MPDSR, the Maternal and Perinatal Surveillance and Response System. For gender, also Mozambique used another system. But even for gender, what I'm going to share is those reported by the HMIS, which means those who came to health facility and treated in the health facility. So comparing 2020 after COVID and 2019 similar months. Let me share my screen. Can you see my screen? Okay. So,
yes, I can. Yes.
Yeah. So the first thing we have looked. Okay. The first thing we have looked at is whether that country have put in place a national continuity plan for essential SRM and SAH services, and this survey was done in May, which is around 2 months after the start of COVID. Fortunately, most of the countries, 68% of the countries in this region has put in place some kind of national continuity plan to ensure that SRM and SAH services are not disrupted. We looked at these various services which are of interest to the 3 agencies, but mostly it touches upon sexual reproductive health and child health. So when you see the red boxes, these are the programs which are not considered in that national continuity plan. So mostly what's been affected is ICCM. ICCM is the Integrated Childhood Case Management. Many countries may not have this program, but this program was overlooked somehow. And as you go further, also abortion services were overlooked in this national continuity plan. And the last also elderly programs designed for elderly, which are not really much in our region. So this is what I said, the elderly person, abortion, ICCM, adolescent and youth-friendly also is overlooked in 3 countries. GBV, risk communication and community engagement is overlooked in 2 countries. When we look at the type of channels used to communicate about COVID, mostly we use the traditional way of TV and radio. 34% is still TV and radio, but also, which is encouraging, is the use of social media. 32% mentioned about the use of social media, mainly Twitter, Facebook, as other channels to communicate about COVID-19. And the others are religious platforms, online platforms, community platforms, and so on. We looked at challenges related with health workers. And mostly 80% of their challenges is about repurposing of staff. Repurposing of staff means those who were working in the delivery room or in family planning or antenatal care, they are repurposed to provide services on COVID facilities or those areas that provide services which for infected or suspected cases of COVID. And mostly there was also fear and stigma. There was a fear and stigma among health workers because of lack of infection prevention equipment, even knowledge and so on. About 20% also say suspected or confirmed case of COVID. Competencies, lack of competencies in terms of management of GBV. All of a sudden, GBV cases are exploding, and they are not trained to manage these GBV cases. Infection prevention and around COVID also was a big gap. So here is the aggregate statistics for 14 countries. Let me just move this one. Yeah. So as you can see, GBV is increased by 72%, but I'm going to show you this is not really 14 countries. GBV data is only available from 4 countries, but it's the only indicator that shows really a huge increase here. With all the data limitations, what we see here is 72%. The rest of the indicators are, if you look at the other increase percentage change, they are within the 10% range. Unsafe abortion decreased by 3%, maternal days increased by 7%, stillbirths 2%, and so on. These figures are not really that significant to make a conclusion that services are disrupted. It's a mixed message. But we look at individual countries. That was the aggregate one. If we look at if we look at individual countries, you can see this is facility delivery. You can see the countries which are most affected: Burundi, Angola, South Sudan, Zambia, and Zimbabwe, and to some extent Kenya. This is a decrease in skilled birth attendance. Women are not coming to deliver at health facility during these 3 months in 2020 as compared to 2019. While on the other hand, you see also increase. So it's a mixed, we can't say really in all countries services are disrupted. It gives us a mixed figure. This is cesarean section. Again, Burundi is as affected. And at that time, February, March, Burundi was having an election also. There are other external factors contributing to this thing. But in terms of cesarean section, 55% decrease in Burundi, Madagascar, Angola, South Sudan, and Zimbabwe are most affected. When you look at maternal days, Kenya comes up here, 96% increase. When you compare, again, it's data. What we have here is a data collected from health facilities. There were 96% increase in maternal days in health facilities without looking at the community days as compared to 2019. And then Botswana, Mozambique, and so on. Stillbirth is also another astonishing figure here. Stillbirth, as you know, happens. Stillbirth happens. It tells you something about the quality of care. Women come to deliver and they're not properly cared for, and then the labor is not monitored properly, and it ended up stillbirth. And if the woman survived, we can count the stillbirth, and this is huge in South Sudan. You can see in South Sudan 169% increase in stillbirths. And you can relate to it because facilities are under stress, under pressure, and care for pregnant women can be neglected, and which is manifested as stillbirth. Unsafe abortion in Eritrea, it increased by 24%, Madagascar, DRC, and so on. And this is also an area where we have very little data. Very few countries provide data on unsafe abortion. What we call here unsafe abortion is all abortion cases managed as a complication of abortion, either sepsis or hemorrhage, all of them categorized as unsafe abortion. GBV, this is the only countries who gave us GBV: DRC, Kenya, Mozambique, and Malawi. You can see in Malawi, 65% increase in GBV when you compare those 3 months, followed by Mozambique and Kenya. So the key message is in terms of policy, most countries have really moved fast to respond to COVID in terms of putting in place the services are continuing, which is encouraging, but still there is, it shows a mixed picture of disruption across various countries. Some are not being very much affected, while others are showing some kind of disruption. So we are continuing to monitor this for the April, May, June as well. No, May, June, July, the next 3 months. And we will see a more solid trend if the trend is due to COVID or lockdown or some other things. It also draws attention to shortage of staff and sexual protective commodities, capacity gaps, and so on. Yeah, thank you very much.
Thanks, Dr. Mona, for that presentation. It's interesting to know that talking about the complications of accessing health services, even the health providers themselves were affected by COVID-19. That's quite interesting. So thanks for that presentation. We'll have you come back shortly. I'm going to have to appeal to Nicholas and Tamari to, as much as possible, see how you can do well within 2 or 3 minutes for your presentation. So I'm going to ask Nicholas to quickly come in for your presentation.
Yeah, thank you very much, Paul. Thank you very much, team, the organizers and the managers of this program. I'm Nicholas Songok from the Anti-FGM Board, Nairobi, and I just want to give you highlights about the cross-border FGM. And that I just want to start by highlighting the data that studies have shown that the prevalence rates of FGM among women aged 15 to 49 in Kenya is standing at 21%. That is as of 2014. In Somalia, it's standing at 98%. Prevalence of FGM in Ethiopia is standing at 65%. Then in Tanzania, it's standing at 10%, and Uganda at 0.3%. And the reason why I'm giving you this data is to give you probably a background on the FGM cases within the East African region, and the countries include Kenya, Uganda, Tanzania, Somalia, Uganda, Ethiopia. And within those regions, we have had movement of people from one country to another for purposes of carrying out FGM. And that FGM, we refer to it as a cross-border FGM. And I also wish to make reference to the research that was done by UNICEF and the board, the Anti-FGM Board in Kenya. And the statistics also shows that the study was done in 2017. It shows that 71% of the respondents during that study from Uganda, 14% of the respondents from Somalia, 60% of respondents from Ethiopia, 17% from Tanzania traveled to Kenya to undergo FGM. And the reasons they provided is that when they cross over to Kenya to undergo FGM, the reasons is that one is that FGM is affordable in Kenya. It's also it's of high quality, and then there's also fear of arrest in native country, and the proximity to circumcisers in their native countries. And it's because of that kind of statistics that during the month of April 2019, I mean, sorry, there was a meeting in Mombasa, Kenya, and the meeting took place between 15th to 17th. And in that meeting, we had representatives from Ethiopia, Kenya, Somalia, Tanzania, and Uganda. They gathered in Mombasa. And there were 3 objectives for that meeting. One was to deliberate on the dynamics of the cross-border FGM practices, including the current situation strengths, challenges, gaps, and recommendations. That was one of the objectives. Objective number 2 was to develop a framework for ending FGM across border, enhance coordination and collaboration. Then the other objective for that meeting was to sign the regional interministerial End FGM cross-border. And that declaration was referred to as End Cross-Border FGM. And as a result of the signing of that declaration, it was formed a technical working group, which was tasked to develop the plan of action, which was based on 4 pillars. The first pillar was on legislation and policy. The second pillar was on coordination and collaboration. Then the third pillar was on communication and advocacy and evidence, data, and research. So those are the pillars which were discussed and arrived at. Then again, as a result of those pillars, a technical working group was formed, and the members came from the regional states. They were able to develop an action plan to address the cross-border FGM. And apart from developing the action plan, they were also able to prepare a monitoring and evaluation plan. And as of now, we have now the costed and cross-border action plan, which was finalized during the month of August. And as I told you, it is costed and it has the monitoring and evaluation plan. And I just want to highlight that during the Mombasa meeting, the regional members, all states committed to eliminate FGM by strengthening regional coordination, enact and harmonize national laws and policies, support cross-border cooperation, develop and implement multi-sectorial costed plan, implement advocacy and communication programs, then generate use of evidence through research, allocate sufficient human and financial resources, develop programs to address emerging forms of FGM, then implement the regional action plan. And of course, as a result of that declaration, we are hoping that when the costed plan is implemented, then we will be able to deal with the issue of cross-border FGM. Yeah, so thank you, and over to you.
Thanks so much, Nicholas. Good to know that lots of collaboration efforts is going on across in your region to combat the increase of FGM. Thanks for that presentation. We'll get back to you during our closing. I would like for Tamari Esho to please do a quick one with us.
Thank you, Paul.
Our presentation, yeah.
Yeah, so I wanted to present around the issue of medicalization. So we know that female genital mutilation is an evolving practice, and as my fellow panelists have spoken, there are a number of things such as medicalization, cross-border cutting of younger girls, cutting of also older women, which we are seeing increasing in Kenya, especially amongst the Kalenjin communities. And this is actually quite interesting because the last 1 week we've had a number of women who supposedly chose to undergo FGM in particular communities in Kericho and also in Narok County. And these women are aged over 21 years old, and actually the oldest was around 32, married and with children. So it's quite an interesting kind of emerging trend that we are really seeing in Kenya currently. And then of course, the clandestine cutting, which means cutting takes place in secret. So the medicalization of FGM is a situation in which FGM is practiced by any category of healthcare provider at the health facility or even at the homes. We see an increase in medicalization of FGM in Africa. And the countries that have the highest burden of medicalization are, for instance, Egypt, that has 42%, Kenya has 20%, Guinea 15%, Nigeria 13%, and Indonesia 65%. And then we see that under or women over the age of 15 to 49 years old, a research that was conducted in 25 African countries show that 51% of 51 million women actually have been medicalized in Egypt alone, and 34% in Sudan. It is not very clear yet the impact of COVID-19 on the medicalization of FGM, and this is something that we need to do further research on. But we know that there's been an increase in the cutting of women and girls during this period of COVID, and most definitely the elite, for instance, who have shown the interest to demand medicalized form of FGM might still be the same ones demanding for the medicalization of FGM. We know we have communities such as the Kuria and people in Baringo who've had mass cutting of girls, and this has been done by healthcare, by traditional cutters rather than healthcare providers. So we see a huge percentage of African, or rather of women who've been undergone FGM that increasingly are being cut by healthcare providers. So if the statistics between the difference between mothers and girls and their daughters that are being cut by medicalization, we can see that the statistics are rising for girls that are being cut by healthcare providers. Just to share an example of Kenya. So we have doctors cutting women about 6.4%, and this is according to the 2014 Kenya Demographic Health Survey. And then we have nurses and midwives also cutting at 8.3%. However, when we are looking at the statistics of daughters, we have nurses and midwives actually cutting more daughters who are at 16%, and this seems to be increasing when we see the level of traditional cutters. This age group of 0 to 14, the numbers of people cut by traditional cutters is reducing while it's increasing on the ones that are cut by midwives, nurses, and also doctors, which we see a clear difference in terms of the mothers. More mothers are being cut by traditional cutters as compared to medicalized cut. If we look across countries in Africa, we see the cadre of practitioners that are cutting, for instance, in Egypt are doctors, medical doctors, and these are more at about 75%. And then nurses and midwives and other professionals is a small percentage of about 10%. When you look at Sudan, on the other hand, nurses and midwives are the ones that are actually medicalizing FGM in Sudan at the rate of about 79%. So we see a mix of medical doctors and a lot more nurses and midwives cutting across the countries in Africa that are medicalizing FGM. And these are Egypt, Kenya, Djibouti, Nigeria, Iraq, and also Sudan. So that was a study by Population Council that I've quoted. Some of the reasons that we see is that the financial motivation for providers to make money out of the cutting. We have heard of facilities in the villages, for instance, in Kisii, that particular private facilities are booming in terms of the business of cutting girls at the facility. There's also the perceived notion that medicalized FGM is a harm reduction strategy. And then, of course, we also see the conflict between cultural beliefs and also the professionals in terms of their professional norms. So providers coming from these particular communities experience that kind of conflict. Additionally, we also see the evolution of medicalization of FGM. So we see that a lot of women who have undergone infibulation, after childbirth, the family or the husband puts pressure on the doctors to return the external genitalia as it was, which means to re-infibulate. So we see that also as something that is happening a lot more. And then also we see the female genital cosmetic surgery also providing a paradox that, a paradox between what is acceptable in the developed countries and what is not acceptable in terms of developing countries. So we see that the issue of women making the choice to undergo FGM is becoming really contentious. And female genital cosmetic surgery is complicating the advancement of the abandonment of FGM. So if this is an issue we need to think about also as we go forward. So why is medicalization against what we advocate for? Because it violates international human rights and laws. It is unethical. And then also it sort of legitimizes FGM. So when healthcare providers or certain institutions advocate for a medicalized form of FGM, it ends up legitimizing FGM, which will bring back the acceleration of FGMC abandonment. And then also healthcare providers, when they do not uphold the do no harm principle, then this also goes against their own professional oath that they take. So in terms of the Center of Excellence where I work in, we operate in 5 African countries: Senegal, Ethiopia, Kenya, Uganda, and Tanzania. And we have implemented a number of sort of community-centered outreaches and approach. And these have included using different kinds of forums that have been mentioned before, like using radio, television, social media. And also we've integrated GBV, FGM, child alien forced marriage within COVID-19 response, especially with community health workers who are actually going to the ground at this time that there were travel restrictions, movement restrictions, and even different kinds of social distancing measures. So this we've done by doing a community outreach where we did a sort of laser targeted approach of households, identifying households with vulnerable women and girls, and community health workers worked with heads of households and families, providing face masks and sanitizers, and also dignity kits, which are branded with AMREF and also with End FGM and End Child Marriage kind of messaging. This we see as a good practice that we intend to continue. AMREF has also implemented alternative rites of passage for a number of years, and we conducted a study to look at the impact of community-led alternative rites of passage. And I'm happy to report that over the last 10 years that AMREF has implemented, the study showed that there were significant changes, such that there was a drop in prevalence of FGM by 24%. There was a drop in child alien forced marriage by 5%, a drop in teenage pregnancies by 6% over the 10 years, and then also, interestingly, an increase in the number of years that the girls have gone to school by 2.5 years. And this was done when we compared the case of Kajiado, where alternative rites of passage have been implemented, compared to communities that have not had this alternative rites of passage. And we did a kind of methodology that looked at the different demographic health surveys over the past 10 years to date. So we are proud to say that alternative rites of passage is a good practice that is actually changing the lives of women and girls. So the approach for AMREF is really to enhance the well-being of women and girls, the health and well-being. And this we do by doing multi-pronged approaches to work with communities, health workers, communities themselves, Pan-African champions, and amongst others, such as the alternative rites of passage that I've discussed. Over to you, Paul. Thank you.
Thanks for that very elaborate one. It's interesting to know that why medicalization appears to be validating FGM, it is actually a violation of human rights. That's interesting. Perhaps as we go on, we'd like to know very specific strategies put in place to isolate the perpetrators, considering the fact that most of them are licensed health providers. So thanks again, Tamari, for that fantastic presentation. If MenEngage Tanzania is ready to make the presentation of the Imam, that would be fantastic. Otherwise, we will just move on to take closing remarks from our wonderful panelists.
Okay, we are ready, and I have Imam, and he can just present. But if he presenting this way, and then I'll be translating.
Okay, if you can do that very quickly in 2 minutes, that would be very fantastic.
Okay, karibu sana kwa ajili ya kupresenti. Hii ni paneli ambapo tutapresenti ni kazi gani ambayo unafanya kama interfaith kuhakikisha kwamba tumaliza swala zima la ukeketaji. I am just providing a short introduction to him so as he can start the presentation. You're welcome, Imam. Sheikh. Yeah. Jitambulisho ni nani? Alafu then unafanya nini?
Asante. Naitwa Taufiki Hamisi Hussein. Ni kaimu Sheikh wilaya Tarime, lakini ni katibu wa kamati ya kamati ya viongozi wa madhehebu yote wilaya Tarime.
Yeah, his name is Taufik Hamisi Hussein. Is the Sheikh in Tarime Mosque.
Okay, we seem to have lost your presentation from Tanzania.
Sorry. His name is Taufik Hamisi.
Sorry, if you can just go ahead, do a minute or two, it's okay.
Yeah, we are facing a network challenge, but his name is Taufik Hamisi. Endelea translate. Endelea, mnafanya kama interface.
Ni katibu pia wa kamati ya viongozi wa dini Interfaith. Tumekuwa tukifanya kazi kwa muda mrefu sasa, zaidi ya miaka 10 ya kupambana na swala zima la ukeketaji na ukatili wa kijinsia, ndoa za utotoni na kadhalika, tukishirikiana na CDF takriban kwa zaidi ya miaka 10 sasa, na mafanikio kwa juhudi za pamoja yameanza kuonekana.
Yeah, he's just explaining that his name is Taufik Hamisi Hussein, working at Tarime Mosque in Mara, Tanzania, but also is the Interfaith Secretary operating and religious leaders in Tarime. He's just explaining that he has more than 10 experiences working on FGM in Tarime, in collaborating with the CDF, and through the efforts of the religious leaders, there is success regarding FGM. So, can you katambia mafanikio umeweza kuyaona?
Mafanikio ni makubwa. Mafanikio ni makubwa ukizingatia na huko nyuma tulikotoka. Dalili zinaonyesha wazi kwamba tumefanikiwa kwa kiasi kikubwa, japo bado hatujamaliza, kwa sababu hata ile misongamano ya barabarani ya wale wanaokwenda aidha kutoka kwenye kukeketa imepungua kwa kiasi kikubwa sana. Huko nyuma ilikuwa ni baada ya lisali moja, baada ya masaa mawili utaona misafara inapita aidha kwenda aidha kutoka kwenye swala la ukeketaji. Lakini kwa sasa angalau kwa siku inaweza kupita misafara 2 au 3 au 1, aidha usione kabisa. Kwa hiyo mafanikio yameonekana kwa kiasi kikubwa sana. Watu wameanza kuelewa.
Okay, he is just explaining on the successes through the effort and the activities they have been doing. The first one, he has explained on increasing awareness to community members, whereby celebrations and gatherings regarding FGM are just going down in Tarime, but also people are coming more aware on FGM, but also the celebrations are just going down compared with the CDF in Tarime.
Okay. Sorry. We are. Hello. You're breaking.
Yes.
Maybe we'll just take you later on, if you don't mind. You just take the time off to face the challenge, and then we can take you later on. Thanks so much. Okay. We're just going to skip the remarks. Thanks so much. Yeah. We're just going to skip the remarks and then go straight to the next session. Joyce will then take you on, and then at the end of Joyce's session, we can then take remarks from every one member of our panel. All right, I'm going to have Joyce come in now.
All right, thank you, Paul, for this opportunity. Actually, this is the second part of the symposium, which was supposed to take an hour, but we just see we have 33 minutes left. So we are going to have a conversation, and I think that it would still work in the 30 minutes, because right now, what I'd like the panelists to do, I'd like the panelists to take minimum time. I'm sorry, I'll be very strict. I'll cut you off if you talk too much, because I want us to engage on various issues. Actually, my focus right now is I'm thinking about the ICPD conference that happened, because it relates to protecting the health rights of the vulnerable. And so we are thinking about this while we are moving forward to fulfill the ICPD promise of action and its commitment. So the question I would like to ask our panelists to just speak into very briefly is, how has the ICPD action plan impacted on sexual and reproductive health of women and girls today? To start us off, we haven't heard from Nicholas in a while. Nicholas, can you just jump in and have a sentence or two? And if you have nothing to say, maybe, or you're still thinking, we could jump to somebody else. Nicholas, are you here? After Nicholas, I'd like to hear from Robert. Nicholas doesn't seem to be here, Robert.
Yeah, thank you very much. This is Nicholas Songok from Kenya Anti-FGM Board. And I want to reiterate and say that as a result of the ICPD conference, which was done in Cairo in the year 1994. Last year, there was ICPD conference in Nairobi. It was running from 12th to, I think, 16th November. And during that meeting, we had the President of Kenya, His Excellency Uhuru Muigai Kenyatta, and he gave his commitment that in Kenya, we are going to strive to end FGM by 2022. And that is a big statement coming from the highest political office of the land. As a result of that commitment, during the month of February, we were able to prepare what we term as an acceleration plan to end FGM by 2022. And it's now the plan that we are implementing. And number two is that as a result of that commitment by His Excellency the President, we have also had what we term in Kenya as multi-sectoral approach to ending FGM, where we have the ministries, the departments and agencies, which in one way or another, directly or indirectly undertake programs to do with FGM. So we are working together. On board, we have the Ministry of Health, the Ministry of Education, the Office of the Prosecutor, and all the other state and non-state actors. And we're hoping that with that plan, we will realize the presidential directive to end FGM by 2020. Over to you.
Thank you so much, Songok, for being so brief and clear. Robert, would you like to just come in and fill it up us on this?
Yes, just a few minor comments to add on to the previous speaker from Kenya. And to say that on the position of the African Union Commission in 2014, for the first time during the, I think the 20-year review of the ICPD, we had for the first time an African policy position on the ICPD plan of action, which resulted, based on on the review that was conducted on the continent, in the Addis Ababa Declaration on Population and Development, where, for the most part, the contentious issues that we have seen around sexual and reproductive health and reproductive rights, amongst other issues, including the engagement of civil society organizations and gender-based violence, harmful practices, received consensus to a great degree. So even those countries that had reservations after the adoption of the Addis Ababa Declaration soon after rescinded those reservations. And so moving forward, we see a consensus from the continent as far as the ICPD commitments are concerned. And following that, 5 years later, in 2019, in Nairobi, during the ICPD conference that was conducted there, the Commission identifies and welcomes very strongly the commitments from a number of countries that came out to voice clear commitments on a number of gender-related issues, including the elimination of FGM. And here we identify very closely with the commitment by Kenya, for instance, countries like Seychelles, countries like Senegal, Ghana, and others who made it very, very clear the push by those countries to achieve clear targets as far as these issues are concerned. And so when you link this to the efforts of the Saleema initiative and through the leadership of the president of Burkina Faso as the African Union champion on eliminating FGM, we align ourselves quite strongly and to push these efforts along those commitments, and we look forward to a great report as we look 5 years down the line on where we stand on this. Over and back to you.
Thank you. That's fantastically done. So I'd like Fatima. Fatima, would you say something? I know in your presentation you mentioned something in relation to this. So could you just briefly tell us what's going on?
Absolutely, yes. I'll keep it short because I briefly mentioned in my presentation, but in terms of the impact ICPD has had, it's been monumental and it's so progressive. And 26 years on, it's still a challenge that exists, and I see it in the comments as well, in the fact that SRH services are not completely accessible and available everywhere. And in particular, over the last few years, I know in Europe, but also globally, there has been a lot of backlash in terms of the progress that has been made. For example, in Poland, there has been a stagnation of providing SRH services for women and girls. So I think in saying this, it's more important than ever to really include this in advocacy efforts and to not only highlight it throughout every couple of years, but to include it as a push and for organizations and activists and community-based organizations to really highlight and ensure and remind decision makers that these were commitments that were made many years ago and are still relevant and should be followed up on. So in terms of the impact, it's been huge, but I think added pressure needs to be continued in order to ensure that this stays on the agenda and is not forgotten. So I will stop here.
Thank you so much, Fatima. That was very clear. Dr. Tamari.
Thank you, Joyce.
All right.
Yes, so regarding ICPD commitments, like my colleagues have already said, we have a very strong commitment from Kenya, and we have very good political goodwill in terms of ending of GBV and harmful practices. So we have currently a medicalization policy that was just signed by the Cabinet Secretary of Health. And this was also as a result of the contribution that we made to the review of the reproductive health policy for Kenya. So now we have also an anti-medicalization policy that is out. So AMREF also has shown clear commitments towards that. We also issued a policy statement against medicalization of FGM. So I would like to call for all organizations and institutions that are represented here and also widely that we need to promote clear statements against all forms of FGM and also its medicalization. So we need to develop different kinds of strategies which are multi-pronged and multidisciplinary so that we also integrate FGM into different wider development agendas such as gender, economic, education, health, amongst other kinds of existing platforms in order to really accelerate the abandonment of FGM. Something else also I would like to say is the issue of addressing social norms. Like the case I mentioned earlier of the adult women undergoing the cut, there's an issue around the rituals and stigma that is happening within those communities. So these are women that evaded the cut when they were teenagers during the time that they should have undergone FGM as a rite of passage, but then they end up choosing under coercion to undergo FGM now. And one thing that has come out of such a community is, for instance, the fact that when this woman has a son that is now ready to undergo circumcision as a male child, she is not able to take care of this child because there are particular rituals that this woman is supposed to do as the mother of the son. But because she hasn't undergone FGM, then she's banished from the ceremony completely. So these are kinds of social norms that we need to address rather than only looking at norms around FGMC. We also need to look at norms that surrounds this individual as a woman and girl within the community, so that we look at the wider aspects of the issue of social norms. So, of course, in terms of tackling medicalization, I advocate also for development of programs for capacity building for healthcare providers, so that they can also learn to prevent FGM as champions and also manage complications. We are all speaking about support services to women and girls, so that we can provide them psychosocial, medical, and even legal support when need be. Thank you, Joy.
Okay, thank you so much, Tamari, for that comprehensive explanation. So I will take Dr. Muna next, but before I do, I can see in the chat box, there's been a concern about ICPD and the promises. Some people are noting that there have been promises to the youth that have still remained theory and nothing has been done to practice it. So panelists, just think about that. So any one of you, after Dr. Muna speaks, can come in and just tell us what it is that they're doing about the youth and whether actually this is being converted from theory to now practice, because we feel it's not being practiced. Dr. Muna, could you please speak about the ICPD aspect down south?
Thank you, Joyce. I think most of it has been said, but what I would like to add is the ICPD plus 25, which was conference which was held last year in Nairobi. It's a sort of celebration also, although there is much left to be done. It's also a celebration. In the past 25 years, a lot has been achieved in the area of right to sexual reproductive health and beyond, and the discourse around fertility control and moving towards providing access to women so that they can have a choice when to have their children and how many children they want to have, kind of approach. A lot has been done, and this has been documented, what has been achieved since 1994. And at the same time, the unfinished agenda has been identified. And if all of us partners focus on the unfinished agenda, especially around inequalities and those who are likely to be left behind from the gains, and protecting these those who are most likely to be left behind would be, I think, a focus area for us.
Okay, thank you so much, Dr. Muna. I'd like to take the question that I just asked, but meanwhile, Sheikh Tawfiq, if you're there, I'll be coming to you. Just, I have one question for you, which you should prepare for very quickly after the comments that the panelists will give. I'd want you to share, don't speak yet, sorry. I'd want you, oh my God. I'd want you to share your experiences on the role of religious leaders towards FGM. So back to the first 5 speakers before Sheikh Tawfiq speaks, can you speak about the youth and the initiatives of the ICPD conference? Anyone? Robert, are you here? Anything? Is it something you need to give a thought to? Because in the box, everyone is asking that question. So
no comment at this time.
No comments yet. At this time. Okay, no. Let's think about this. Meanwhile, Dr. Tamari, you're waving. Please go ahead.
Yeah, thank you. Yeah, so really engaging the youth is really important, and that's something also we do at AMREF. And we focus on meaningful youth engagement. And of course, we see youth as this energetic, bunch of people who are really engaging in social media, engaging in different platforms, taking part in End FGM and NGBV campaigns, really being at the grassroots and understanding what's happening at the community level, and also them being part of it. So it's really important to have strategies to engage the youth meaningfully. And yeah, thank you.
All right, Fatima?
Yes, I just want to echo what Dr. Tamari just mentioned, and likewise at End FGM European Network, we also really value the advocacy and power of youth voices. And myself, I started off as a youth advocate. And in terms of integrating and supporting youth in receiving services, SRHR services, what we think is very important is the fact that young people are included as part of this dialogue, and that the inputs are included in every part of the process in the same way that we would advocate for organizations, and especially grassroots organizations, to be included. And in terms, and alongside that, one of the things we do is with our youth ambassadors, they've created a YouTube channel in utilizing what Dr. Tamari says. They're very much online, and in their, with their channel, they not only talk about FGM, what GBV is, but they also provide information on how to receive information and services, and how to go about also advocating on this topic. So yes, including youth as part of the dialogue is very, very crucial and important in progressing in this.
All right, Nicholas.
Joyce, just a very quick one.
Yeah, okay,
just a very quick one.
Wait, let Robert
Nicholas Songok from Anti-FGM Board.
Okay,
Nairobi.
Go ahead.
Yeah, I want to add that one of the commitments of the ICPD was enhancing the population dividends, and that out of that it was realized that we have in Kenya, the youth population is big, and they have a lot of energy. And in implementation of those commitments, the government is doing quite a number of issues. They are engaging youth. We have, I think, a program by the name Youth Mashinani. There are also Ajira programs for the youth. And although in a way it looks like what we are doing is a drop in the ocean, because at the same time we are not able to, the government is not able to engage all the youth. But then those are some of the baby steps that we are taking. Now the other issue is that as an FGM board, when we are addressing the issue of FGM, we have come to the full realization that if maybe we use the youth, then we are going to go far. Because you look at the youth, and the marriage age is probably that age of maybe 20 to 30 or thereabouts. And that when we use them to advocate or to pass anti-FGM messages, then we realize that we are making progress. The other issue is that in Kenya, we have youth who are doing border border, and we are using them by way of, we normally give them the jackets, the reflector jackets with the anti-FGM messages. We have also been having youth caravans who assist us in passing anti-FGM messages. Now, finally, the issue of religious elders. As anti-FGM board, we've been working with the religious and cultural elders. We have had quite a number of forums with them, and we try to impress upon them that in any platforms that they're having, be it when they are preaching and in any other fellowship meetings, then they can assist us in carrying out anti-FGM messages. And above that, we have come to the full realization that when you look at the Quran, the Bible, it doesn't support the issue of FGM. Over, and thanks to you.
Thank you so much, Nicholas. Robert, do you have something to say?
Just very quickly to identify with comments from Fatima. I was indeed myself a youth advocate for a number of years, and could not emphasize more the need to make sure young people are at the table in defining action on this. But generally, within the context of the work of the African Union, to say that the African Union has a special youth envoy who carries a very strong mandate and has been implementing such strong programs around a number of issues, including on ending harmful practices, on ending female genital mutilation. She has just recently conducted a number of consultations across the continent to solicit views and recommendations from young people towards a roadmap on a response towards the end of COVID-19. And in there, you find a number of ideas, a number of strong recommendations, including on ending GBV and on ending female genital mutilation. So just to connect to that momentum that is created by the Envoy's office, there's a wealth of information there that I would rather speak to more through what has been produced by that office, and to point everyone there.
All right. Thank you so much. I'd like to bring to your attention that please check the chat that is taking place, especially the panelists like Tamari. There are questions on medicalization, which you can type there. Because of time, you can type or share links there. And then somebody has shared, is it Fatima? Yeah, Fatima has shared a link on the Purple Chair, a YouTube channel that speaks to the youth. So all participants are welcome to just log in and check. I'll be talking to Sheikh Tawfiq in a bit about religious leaders. Meanwhile, the panelists, I'll just want you to think about the strategy or the relevance and experiences on engaging men and boys in ending FGM. This will wrap up our session. So think about that as we speak to Sheikh Tawfiq about religious leaders. Sheikh, are you ready? Are you here now? It seems we are having trouble with the connection. So can we please quickly go back to our panelists? I'd like you to tell us about the male experience, or rather the experiences you're having in engaging men. And each of you will have 1 minute strictly to speak about this. Maybe this time I should start with, whom can I start with? Anyone ready to speak about the men? Okay, yes. Go ahead. Yes.
We are ready.
Oh,
yes, we are ready.
Okay, please speak. Okay, Jovitas, I think what you should do, please type in whatever you wanted to tell us, because we are running out of time. Kindly write in the chat box, then I can read that loud. Kindly type in the chat box. Meanwhile, panelists, we are short of time. Can we please speak about the men and boys? Dr. Muna?
Thank you. Just quickly, to give practical example in the area I am working on maternal health, without the involvement of men and partners.
I am bringing Sheikh Karibu, mchango wa viongozi wa dini katika ukatili wa kijinsia.
Okay, so it's just to highlight the importance of men and partners in the decision making and in the area of maternal health. And we have seen that even if women have the knowledge, unless they have the support from their husband, simple things like traveling to a different area without the agreement of the husband or the partner, and usually the breadwinner is the husband or the partner in most areas, and without having them on board for anything related to health-seeking behavior would not make any fruit, long-lasting fruit, without engaging male. Over.
Thank you so much. Nicholas, are you there? Can we please hear about how you?
Yeah, I'm getting you loud and clear.
Okay, go ahead.
The role of men and boys in ending FGM and other cultural practices, including the other forms of GBV. Africa and probably in most of the countries, we are in a patriarchal society. And that in most cases we have been having men making decisions, and that means that if maybe we need to win the war against these practices, then the voice of men is going to be very important. If we are able to convince the men to say no to the forms of GBV, then we are going to succeed. Number two is that when you look at the families, the decision makers, again, in most cases and in most areas are also men. And again, within the family setup, if we have men saying no, then we will be able to get success. Number three, we have men also as religious leaders and as career elders. And if they're able to say no, then the other one is that even at school, we have boys and girls, and that whenever FGM or GBV programs are carried out, then we need to target the boys and girls so that they are then able to support the girl child. Because at the end of the day, it's the boy who will marry the girls. And if they say no, then we will win the war.
Amazing, amazing. Fatima?
I can go. I'm sure we've all heard the saying that FGM is often carried out by women for men. And I think, as was just mentioned, we live in a patriarchal society, and so without involving men and boys, it's really necessary to eliminate FGM. And while saying that, I think it's important to highlight that women and girls should still be at the center of everything to do with ending FGM. But one of the points I'd like to make is that it's really important that initiatives engaging men and boys are funded, and especially religious leaders, in order to continue tackling this practice. I think it's essential that we also recognize that there should be dialogue and spaces created for men and boys to have discussions, women and girls to have discussions, but also for there to be spaces for both to have a conversation, because evidence has shown that once they're both included in the same room and they have this open discussion, that concrete solutions can be found in that way very easily. So I think it's really important to support these initiatives and for this to be highlighted. At European level, actually engaging men and boys and religious leaders have been included in policy processes in the European Parliament and Commission. So we know that our members have been using this to support and push for more engagement with men and boys. So thank you. Over.
Oh, okay. And each panelist should prepare their punchline. You will get 3 seconds to give your punchline after this. After Robert speaks, I will hand over to Paul, give your punchlines as we finish. All right. Paul, what's the AU's position? What are you doing?
You mean Robert?
Robert, oh, sorry, Robert.
Yes,
thank you, Robert.
No problem. But no, just to identify myself with a lot of the great comments that have been made by Nicholas, by Fatima, and others on this. Indeed, if you do not make sure that men are there to say no, as we've said before, when you look at the many communities where men were put in the shoes of, or rather shown clearly what the impact of FGM, especially on a woman or girl's body is, they quickly denounce the practice or quickly dissociate with the practice. But overall, at a policy level, men are the ones who are sitting around, who are predominantly the ones making the decisions. If you look at in the practice of FGM medicalisation, for instance, the ones who facilitate in economizing, in making this a money-making venture, really, are rather men as well. In cross-border practice, the ones who facilitate the logistics of moving families from one place to another, predominantly men. And so we need to be able to make sure that we are able to denounce this practice, but also giving men that position of being the ones who denounce it, because, of course, it caters to the patriarchal system that is defining society. So thank you, and over and back to you.
All right. Actually, I will wrap up this session by reading what Sheikh Tawfiq has written. In regards to the role of religious leaders in the fight against FGM, Sheikh Tawfiq says religious leaders are first responsible to use the churches or the mosque worshipping sessions to raise awareness of FGM, because most people are not aware of this practice unless the communities that practice it. So condemning bad cultural practices, including FGM, but they also seek to force the government to implement various laws and international contacts signed to protect women and children. So that is what they say, the Tanzanian team say as per the Sheikh. I'd like to thank you very much for giving me this opportunity and participating. I'll hand over to Paul to wrap it up. Thank you so much.
Well, thanks so much, Joyce, for that wonderful work. It's nice to finally get input from Tanzania. Thank you for sending that in. Imam. And to our panelists, I would like to thank you very profusely for great work that you've done and the information you've shared, and especially to those of us who shared links on our chat box. Participants, thank you for the questions and the comments and for coming on time. Yes. And special thanks to Meba for coordinating all of this. I'm sure she's still there. Thank you, Meba, for the opportunity as well. We are just right on time. Summarily, finding solution to a number of these challenges will have to be an all-inclusive thing. The women, the men, the boys, the girls, the youths, we all have to put hands together, especially when it comes to ending FGM. Again, I'd like to thank you for your contributions and for participating. And to Joyce, thank you very much for the pace and the energy you're bringing in. Thanks so much. All right, from my end and from Lagos, Nigeria, I'd like to say a bye-bye from us. And over to you, Joyce.
Oh, me again. Okay,
Yes.
Punchlines, one word each panelist. Jump in. Anyone? Tamari? One word.
Yeah. Thank you very much.
One word, Nicholas.
I'm requesting all of us to become champions against FGM.
Champions against FGM. Somebody else?
And female genital mutilation in this generation.
Oh, no female genital mutilation in this generation. Tamari?
Strengthening partnerships and collaborations.
Partnerships and collaborations. Fatima?
Ending FGM for all.
Okay, and Dr. Muna?
No GBV.
No GBV. Also, we didn't speak about that. Let's have this again. Organizers, 2 hours was not enough. Can we have this again next week, maybe? Thank you all and have a blessed evening.
All right.
Thank you.
Right. Bye.
Bye.
Thank you. Bye.